Good day again, folks, and welcome to the first of two lectures that we will be speaking about with regards to justice and human rights in healthcare. This is the first of two lectures, okay? Uh, just to remind you, when we talk about health resources and justice in healthcare, what's the real issue at hand? And the issue is that, especially in Trinidad, we exist in a publicly funded healthcare system that is funded by limited and, depending on which country you're from, sometimes very scarce resources. And the aim of most publicly funded health systems is to provide equal access to healthcare for those in equal need. And of course, the ethics of health service distribution can be considered at three levels: globally, nationally, and individually. We'll be talking about national and individual concerns in this lecture, and we'll be addressing global ones in a subsequent lecture. So, just some definitions. Justice is defined as being linked to fairness, entitlement, and equality. And there are three categories of justice. There's the fair distribution of scarce resources, respect for people's rights, and respect for morally acceptable laws. And two elements of the, just to remind you, two elements of the principle of justice. There's equality and equity. Which one are we looking for when we speak about justice in healthcare? And I'll refer you to the image we saw in the lecture, right? So the one on the left represents equal resources being given where resources are represented by the boxes, and equal resources are being given to different members of society. So the little guy on the right maybe represents somebody from a lower socioeconomic class. The guy in the middle probably is a middle class person, and the guy in the blue jersey on the left hand side we'll say a bit tongue in cheek upper class, right? Um, but regardless of their status, they all receive equal resources. Um, However, this is what we really want to achieve, where everybody, the outcome for everybody. So on this lecture, on the box on the left, despite the distribution of equal resources to everybody, the outcomes are very, very different, right? However, in the box on the right, where resources are not distributed equally and they're distributed according to patients' need, then the outcome for everybody is the same. The health outcomes are the same, and this is what we're looking for. So we could see the diagram on the right shows equity, and equity is the whole point of justice in healthcare. That's what we're looking for. However, this is what actually happens in reality, right? The box on the right hand side, where the more disadvantaged in society, their health outcomes are very, very poor compared to the more advantaged. And what is the WHO definition of equity? And equity is defined as the absence of avoidable or remediable differences among groups of people, whether these groups are defined socially, economically, demographically, or geographically. And when we speak about health inequities and health disparities between different groups of people, these are types of unfair health differences closely linked with social, economic, or environmental disadvantages that adversely affect groups of people. So the route to achieving equity will not be accomplished through treating everyone equally, as we saw in the diagram, where everybody in the first box, everybody got equal resources. That's not the route to achieving equity. It will be achieved by treating everyone equitably or justly according to their circumstances. So just a brief touch on some global issues. Why are there global inequalities in healthcare on a global scale? Of course, lack of money in so-called LMIC, low to middle income countries. These LMIC countries have poor infrastructure. Poor infrastructure leads to inadequate training facilities for doctors. Doctors become frustrated in these countries. They want to go to first world countries, so there's a brain drain. These first world countries, they have a lack of staff. So they actively engage in poaching medical staff from developing countries. And in Trinidad, we are a developing country, remember, right? So you all may be being poached to go to the States or the UK or Europe. And of course, during a new issue now during a pandemic, there's hoarding of material, especially by these first world countries, right? So we won't go too much into the COVAX facility because we spoke about that in great detail in the lecture, and that's what your debate will be based on, right? So on a national level, in our local experience, in 2013, the Ministry of Health allocation was 4.2 billion out of a total budget of 59 billion. That's approximately 7%. So basically what the government is saying is that only 7%, they could only spend 7% of the money they have for health of the population. Is that fair? In 2019, the MOH allocation was 4.9 billion. It went up a bit out of a budget of 55 billion, but it's still about 9%, less than 10%. And we don't have any figures since then. And with COVID, of course, the situation was much, much worse. So the issue is that we have finite resources with which to achieve a just distribution of healthcare, and is this feasible? And we've seen the reality box diagram, and in most cases, not feasible. We have to try. Right, so on a national basis, again, the factors affecting access to treatment: age, socioeconomic background, ethnicity, culture, disability, legal capacity, insurance coverage, and prognosis. How does age affect somebody's ability to access healthcare? There's a rationing of treatment based on age and one's ability to recover from illness, so-called ageism. Socioeconomic background: evidence that patients of lower socioeconomic backgrounds are more unhealthy, sometimes simply because they just can't, they're working 2 or 3 jobs and they just don't have the time to access healthcare, right? So that's one big factor when it comes to patients' ability to achieve healthcare. Ethnicity: well recognized in research that non-white patients tend to be more unhealthy and have greater morbidity and mortality when ill, especially in America, the Black populations, Hispanic populations, the Native American populations. Culture: homosexual and transgender patients also have greater morbidity and mortality when ill. Disability: again, going back to rationing of treatment because of mental illness. Mental illness is still considered a disability, or poor quality of life, poor functioning at home. Lack of capacity: again, rationing or lack of treatment in those patients who lack capacity to make medical decisions, a tendency just to override them and to deny them care, especially if the illness is very severe. Insurance coverage: those who can afford insurance coverage have access to private hospitals. Should this be allowed? And we went into detail of this in the tutorial, right? So just some practical examples of national resource distribution. We have our own Trinidad and Tobago Health Service, which is a public health system. The National Health Service in England is also a publicly run system, and the New Zealand Health Service, which is also publicly run, right? In our local situation, health provision was devolved from the Ministry of Health to 5 regional health authorities in 1994, so-called RHAs. And these RHAs, not the ministry, but these RHAs make all the decisions pertaining to resource allocation and who gets what, right? Depending on which area you're from. So the problem with these large bodies, it doesn't matter Ministry of Health or RHAs or clinical commissioning groups in the UK. There's always not enough public representation to these bodies, so vulnerable populations continue to be disaffected. So you don't have people with mental disabilities on these boards or these committees that represent vulnerable populations. You don't have people from LGBTQIA backgrounds on these committees, right? So again, they continue to be underrepresented, sorry. Another issue: inequitable distribution of financial resources amongst the RHAs. The RHAs get money from a certain amount of money from the Ministry of Health. It's well recognized that the Southwest RHA has the biggest catchment area, but does not receive as much money as the other RHAs, right? Mismanagement, always an issue. Political interference, always an issue in Trinidad. And then worldwide drug and material shortages. All of this has been compounded by worldwide drug and material shortages induced, 1, by the COVID pandemic, and 2, by the war in Ukraine, right? As with the war of Ukraine, there's an energy shortage, and that energy shortage has a ripple effect throughout the entire world. So we'll gloss over the issues of the NHS. But never, whatever public health system you look at, both systems, so our health system and the NHS and the one in New Zealand, all systems rely on horizontal resource allocation. But the issue is who makes the decision? Is it us, medical professionals? Is it lay people? And if it is medical professionals, why do they get to decide? Who has appointed us to make the decisions um, for, let us say, vulnerable populations? What gives me the right, doctor, to tell me? Say I was on a committee. What gives me the right to make decisions as who gets medication, who gets the hip operation, who gets the hernia operation, who gets the Zestral for the hypertension, who gets the glucophage with the diabetes, right? Who makes the economic evaluation? I'm not economically trained. I don't have any background in economics. So how can I make this work, right? And there's again in Trinidad nefarious is always the influence of politics and public opinion to consider, right? So just to point out, in New Zealand, this is the only health system in the world where healthcare rationing is made very, very explicit. Guidelines are published for specific conditions and the rationing of available resources. So, for example, patients aged over 75 and or with comorbidities, they can't get dialysis if they're in renal failure, right? It is very upfront, right? The public knows about this, but this is not that kind of explicit healthcare rationing is not made clear in our health system nor in the NHS, and sometimes that causes a lot of issues sometimes with the public. So the basic challenge with any public healthcare system is balancing public demand against something called distributive justice. And the definition for distributive justice is determining what is fair when decision makers ration available resources. And justice, again, requires that everybody gets the resources needed to be healthy, a basic level of health. Okay. So how do we ration? One option is triage. Um, Patients are screened in order to determine their priority for treatment, usually practiced in a military or mass casualty setting. And those who have a chance of survival are prioritized ahead of those who will survive without treatment, as well as those who will not survive even with treatment. Do we use a merit-based system? Health resources are distributed according to the individual's net worth to society. Allocation tests like these are beyond my scope as a medical professional, and there's always a bias against those the elderly and those with disabilities, right? Because they're not considered to have any merits. So the main technique that we use to ration and to employ the concept of distributive justice is something called QALYs. The concept of QALYs, quality adjusted life years. So 1 year of healthy life is scored as a 1, and 1 year unhealthy life is scored less than 1, depending on what kind of morbidity you have. So for example, if you're bedridden, um, your score is 0.5, right? And if your death is scored as 0, and sometimes life, worse and death is scored as a minus. And data based on these QALYs, data on medical costs can be combined with QALYs to estimate the cost per QALY of a medical intervention. And we discussed this in the tutorial, right? So the issue with QALYs is that they operate to the disadvantage of the aged. They only measure the endpoint of treatment, not the proportional gain loss of quality of life. Other parameters do exist which contribute to the quality of life that need to be included in the equation, and they set no value in life itself, right? They just reduce life to a number. Okay, so here ended the short video presentation on justice and healthcare 1. The subsequent lecture will be a further discussion entitled Justice and Healthcare 2. So I'll see you for that lecture. Thanks very much for your attention.